Dr. Birendra Sir, President, Dr. Ashok Sir, Dr. Pranab Bhai, Rajesh, who left no stone unturned to make the conference of CME a grand success. Brothers and sisters from Bihar, my friends, colleagues, and respected senior persons. Possibly, this is the 30th year that I am coming to Bihar. I first came in 1993 in Dhanbad, in Pataliputra Medical College, when Bihar and Jharkhand was a single state. So for 30 years I am coming. It is almost my second home. Sir, with your kind permission, President, I requested Dr. Birendra Sir long ago to take up soft tissue tumors in CME, because what I have gone through for last 30 years, almost all areas have been touched except soft tissue tumors. Soft tissue tumors has now approached to such an extent that starting from morphology, it has gone to IHC, and not IHC, even to molecular levels. So we should at least upgrade ourselves, what is happening in the different parts of the world, not to keep ourselves within this Bihar or in a subcontinent or in a state. So that is why I requested Sir to take up soft tissue tumors. He is kind enough to take soft tissue tumors in whole day CME, but it should be better if we have taken 2 days for the CME because it's a huge topic. So the topic is approach to diagnosis of soft tissue tumors with recent trends and current evidences. So this is an international conference held last year, 2022, for 2 days in Bangladesh, where there was a lot of lectures on soft tissue tumors. Not only that, we find that in November 15 to 20, 2022, in Baltimore, Maryland, they held an almost half-day CME on soft tissue tumors about the recent updates. So see how it is progressing from one area to other on soft tissue, which is a very intricate and very delicate area. And I am very grateful to Dr. Bharat Rekhi, who is considered one of the topmost soft tissue tumors, to invite me as a chairperson in his own symposium that was held in Gwalior hardly a few days ago. And he invited me to chair his session on soft tissue tumors. Now what Dr. Juan Rosai has told, he has told that under microscope we can diagnose almost all tumors without the need of IHC and molecular. That was his days when only morphology was diagnosed, but not the intricate genomic profile or the proteome, the phenotype, genotype. What is cancer? Cancer is a genetic disease driven by oncogenic mutations. So all types of mutations play. What is intratumoral heterogeneity and what is intertumor heterogeneity? Intertumor heterogeneity is that with the primary tumor has a genetic profile and the metastasis has different genomes. So that is why tumor progresses. We treat the primary, but the secondary becomes aloof and recurs. This is intertumoral heterogeneity. And what is intratumor? That is the most dangerous part. Inside the tumor itself, there are cells which differ in genomes and in phenotype. These areas need diagnosis, not only diagnosis, treatment, because treatment is advanced to such an extent, we are doing limb salvage therapy. Previously, we are going for hindquarter or forequarter amputations. But nowadays, we are doing limb salvage therapy by targeted therapy, personalized therapy, and immune checkpoint inhibitors. So these are coming, and for this, we should upgrade the soft tissue tumors to at least we should have a knowledge on this topic. So this is a heterogeneous neoplasm. I have already told you 80 different types have been described. 1/3 have specific genetic signature, means they can be identified by genetic profile. IHC and molecular techniques But what happens? Not only there is overlap in morphology, there is overlap in IHC. Tumors showing CD34 positive, many tumors, spindle cell tumors have CD34 positive occurring in different parts of the area. So CD34, is it a marker of solitary fibrous tumor? No. Then what we have to do? We have to do genetic profile. What is genetic profile? We have to do STAT6. If STAT6 come in the IHC, then we can stamp it as a solitary fibrous tumor, because CD34 positive tumors occur in various other regions. So according to HO, soft tissue tumor is classified into 12 groups, which I have not highlighted over here. You can get in the textbook. But what IHC plays an indispensable role in defining tumor histogenesis and also serves as a surrogate for molecular alteration. So IHC is a must nowadays for before stamping a tumor that this is diagnostic of this. This is very important. We cannot get away from this because we do not do IHC diagnose on the morphology, but send it to higher centers for IHC for confirmation. So not that we are not derived, we can diagnose by morphology, but for better treatment to the patient, we have to refer to somewhere where IHC is being done. So what is our idea? Idea is patient's treatment. Correct diagnosis, patient's treatment. That is our protocol. So for that, we have to take the help of recent technology. So what is pattern-based diagnosis helpful? Pattern, suppose patternless pattern of growth, where we find in solitary fibrous tumor. And these patternless patterns, so you can find that hemangiopericytomatous growth pattern is found in various tumors. So can we label as hemangiopericytomatous growth pattern with patternless pattern of growth in spindle cell tumor as solitary fibrous tumor? No, sometimes it creates problem. And moreover, if we do CD34, you can see that so many tumors are CD34 positive. So in these cases, we have to take the ancillary techniques, and for this solitary fibrous tumor, we have to do STAT6. So let us see how it happens. What is this? Spindle cell tumor, isn't it? Hemangiopericytoma like blood vessels. Then we do STAT6 solitary fibrous tumor. Another tumor, again hemangiopericytomatous with spindle cell appearance. We do IHC, which is TLE is positive synovial sarcoma. So see how it differs, even in histology, not to think of cytology. Same pattern, hemangiopericytomatous spindle cell tumors, haphazardly arranged, some arranged in clumps, some seeds. So similarly, another hemangiopericytomatous like arrangement, and this is positive for S100, which is a MPNST. This is also hemangiopericytomatous spindle cell arrangement. And this is positive for myogenin, which is strongly positive for spindle cell rhabdomyosarcoma. This is also CD calretinine positive, again hemangiopericytomatous like blood vessel desmoplastic mesothelioma. So many tumors with spindle cells come in the picture, and only CD34 positive will not give a clear-cut account. Now, what do you do? Don't be afraid of diagnosing soft tissue tumors. Feel confident in yourselves. I will go what we can do even in peripheral part. These are the things which is developing in the higher centers, which one must be knowing this. One must keep ourselves updated, but that does not mean that we will be scared to diagnose. No, we can diagnose by morphology alone if we take clinical picture, CT and the cytology. Fusion genes can be detected by FISH, and fusion genes produce fusion proteins which can be detected by IHC. So these are the two things. Use of IHC as a surrogate that I have already told you, solitary fibrous tumor, positive for STAT6, which highlighted NAB to STAT6 gene fusion. So this acts as a surrogate for your molecular profile. Diagnosis of soft tissue tumor, how you can, now I am coming to what we can do. One is that you have to do thorough clinical examination. Not that just putting the needle, clinical type, see the tumors, Feel the tumor, fixity of the tumor, whether it is rounded, whether it is diffuse, whether it is painful, painless, rapidly growing, slowly growing, deeper structure adherence, all we have to see in soft tissue tumor. Then take the help of radiology to see where is the origin. This is very important. If we do CT with contrast, we can detect the origin arising from muscles, arising from bones, arising from nerves, arising from blood vessels. Yes, the radiology can help you, and if we can get a clue that where it is arising from, then we can give a confirmative diagnosis, whether dealing with a rhabdomyosarcoma or any vascular tumor or any neural tumor like that. So this is very important for radiology to cite. So clinical radiology and the site, we have to get the appropriate material for FNAC. Not that putting the needle and non-representative material will not do. We have to get that proper representative material. And that is most important, one of the diagnostic criteria. Then step one, smears. What we find in the smears? Then smears, we have to do morphology, arrangement of cells, background. What's morphology? Round cells, spindle cells, epithelioid, pleomorphic, and mixed. We should go slowly. See the cells. First, see the cells. Then, see the cellular arrangement, whether they are discrete, whether they are palisading, whether they are fasciculated, whether they are in groups, whether there is rosette formations, all these areas we have to see. Apart from that, we have to see the background, whether there is tigroid background, clear background, myxoid background, fatty background, and all these background we have to take into consideration before giving a diagnosis cytologically. Not that only cells, see the background, see the arrangement of the cells, then only we can move. The cells, now we have to see whether they are epithelial, mesenchymal, or lymphoid. This is important because they are treatment-wise totally different, epithelial, mesenchymal, and lymphoid. Epithelial carcinoma, then soft tissue, and the lymphoid tumors. We can do IHC and cell block with, we are in doubt. Tumor behavior, we have to level whether it's benign, intermediate, or high and low-grade malignancy. Specific IHC we have to do, already we have told that is a histogenesis and surrogate for molecular. And molecular testing we can do by FISH RT-PCR and next generation sequencing. Who should perform? This is a thing which we have highlighted in almost all centers, including in Baltimore, Maryland. We have told that a cytologist should do FNAC, not a radiologist, not a surgeon. Why? Why a cytologist should do? Because we have to do rapid on-site evaluation. See the material, whether representative material has come which corresponds with our CT picture. We have to do FNAC from multiple sites, from the central part of the lesion, from the peripheral part. Peripheral is the growing part, central part the static part. So those areas we have to puncture and see the cells, how the cells are proliferating, and compare our cytology with the imaging technique. The images tell that's a growing tumor, rapidly growing, though then we should repeat if our cytology material does not correspond with the radiology. Majority of the cytologists do not take into account the radiology, and that is the most important loopholes of a cytologist in our country. They do not consider the radiology, they only put the needle, because I have seen in our WhatsApp group material from bone. Arey, what is this bone? This is a bone tumor? And if bone tumor, show the X-ray. Whether it is lytic, sclerotic, or sometimes infiltrating the bone, nothing is shown. And if we ask the tumor, sir, patient has not sent, then do not see the slides. Do not see the slides, tell the patient to bring it. Pranab usually gives lot of importance on radiology. I have seen, he always asks his second question, what is the radiological findings? Excellent question he asks. But majority do not highlight. He always highlights anything he gazes on cytology. Second question is, what is the radiological findings? Give me total clinical profile. He is very, very, very good teacher, but hardly anyone follows him. That is the drawback. So this, if cytodiagnosis is equivalent to histopathological diagnosis, then we have to take the ancillary techniques, because we have to do at par with the histology. If we have to take neoadjuvant therapy, targeted therapy, if we have to do, then it should be at par with the histological diagnosis. Advantages of FNAC, because majority of us tell that FNAC has nothing to do, but it has a lot of, provided it is done by cytologists. Multiple sites, to cut one or maximum two areas, but in cytology multiple areas. Number two, the tumor may be covered with a necrotic slough. So avoid this necrotic slough, we can go the deeper part, which a punch biopsy usually takes a necrotic slough, but we can overcome it by putting a needle and getting adequate material. CT guided technique in deep seated like parapharyngeal area or paramaxillary areas. Quick technique, less trauma, can FNAC yield, can be replaced cutting biopsy. That is a challenge to us. What is microbiopsy? Once we get the aspirated material, immediately we make smear. No. Once we get the aspirated material, we should put in a slide, see whether there are chunk of tissues are coming out, particularly in bone and soft tissue tumors, because they come in a pretty advanced stage. So if the chunk of tissue is there, we can process it at endoscopic biopsy. And this microbiopsy can be detected by magnifying lens. It is the architecture of the mother tissue is preserved and is a substitute for surgical biopsy. Now classification broadly we do